Before we go on to our discussion session amongst ourselves, I thought I'd take a moment to see if anybody in the audience would like to ask any one of us a particular question or start off our discussion. So does anybody?
Do you foresee, with this culture of robotics, do you foresee a bigger role in the OR for the robotics, such as opening, retracting, and closing? You know, aside from implant cuts and implant placement, do you see a bigger role?
As far as soft tissue management for joints,
Right.
I really don't. I don't think we're heading to Da Vinci-esque robots for orthopedics. You know, it's the utility, the value add for us is really CAD CAM. You know, because that's what orthopedic robots are. It's just CAD CAM. I just don't know how much value added there is for that type of automation. You know, it's not as delicate and fine surgery as, say, you know, open heart surgery or that kind of thing, or even spine surgery.
Anybody else on that?
I think it's a great question. I think where we sort of are thinking, right, maybe as more junior surgeons being excited about what happens in the world around us. I mean, nobody got here in a car that wasn't fixed by robots, right? It completely is put together, and there's just a couple guys on the floor that oversee in these new facilities. So we should not close our eyes for the fact that robots now can sew your jeans and your suit, right? Because of optics and machine vision, the textile industry has literally spent billions of dollars figuring out how to get people away from the sewing machine. And with machine vision, they've been able to figure out textile. And textile is very difficult, right? Because textile can move different ways, and it is stretchy and all this kind of stuff. So since that has been done, I know there is a robotic company pretty far along with actually being able to close universal wounds. So it's still not an exposure robot today, because that might be bleeding and bovies and, you know, all kinds of stuff. But if you have a wound with a reasonable amount of anatomy, with the fascia, subcutaneous fat, and then skin, we're very close at just telling the robot, okay, look at it and close it up. And the soft tissue tension is going to be better than any adult reconstruction surgeon will ever do per stitch, right? Certainly better than the medical students and the residents that normally get left to do that job, leading to maybe the 1% infection rate and so on because of dragging tissues and stuff like that in the wound from the skin. The suture thread touches things it shouldn't be doing. Right. So I have great hopes that, in all honesty, and just remember this meeting, between now and 10 years from now, a simple, at least in the spine, operation will be done 75% by a robot. I really think so, because of the machine learning and the ability to be able to see and then close the wound in a more predictable fashion. So it is very close. Right. It is very close.
No, I'm optimistic with that. Thank you.
I think from a soft tissue standpoint, though, what's, at least in joints, what's valuable is assessing ligament tension, you know, and balancing the knee. And what I'm seeing with robotics is that it's completely changing the paradigm of how we balance knees and how we think about gaps. You know, I talk about kinematic knees. When I've seen surgeons use the Mako that are not kinematic surgeons, they're actually doing some variant of kinematic knee replacements because that's what the computer is telling them to do, because that's where the knee wants to be. So that's the value soft tissue-wise, that we're getting information that we just didn't have before.
Sure, sure. Yeah. That's great. Thank you.
Thank you very much. Actually, while we're on this topic of robotics and knees, I would actually ask Dr. Jacobs to jump in on this, being in a knee surgeon for 30 years, and his thoughts on where we are today and where we're going with robotics, and actually any advice he could give to the engineers in this audience on what they should be thinking about that could help him in the OR with the current technology, taking it to the next incremental step.
So what I've heard from my two colleagues here is just a wonderful vision of the future. It's really exciting and inspiring, and I sure hope we get there. However, where we are now makes me wonder, how are we actually going to get there? So I'd look to some of our sister specialties, urology, gynecologic oncology, general surgery, et cetera, where I think robotics is now the standard of care in many of these operations. And if you're not doing robotics with some of these operations, you're going to lose your patients to other medical centers that do it. The fascinating thing is I think the evidence base to support it is a little shaky. There are some studies that may show some benefits of the Da Vinci in certain cases. There are others that maybe aren't as supportive. And so being the, the kind of the curmudgeon-y, gray-haired academic in the panel here, I'm going to be convinced with evidence. And so all of what we heard today, of all these really promising, bright technologies in the future, unfortunately in orthopedics have led us astray in some cases, and have led us astray badly. So for example, this afternoon I'm going to do yet another interview with a national news organization about metal-on-metal bearings. And the current concern has been brought up on the Netflix video, The Bleeding Edge. Have anybody seen that, Bleeding Edge? Please look at it. It's not necessarily accurate. Actually, it is not accurate. It's horrible journalism. It's unbalanced. Yet that's what the perception is of your industry and of our industry to some extent, and the FDA. And so, again, these things keep coming up. Anybody see the John Oliver segment on orthopedic devices? Based on the Netflix interview, Google that one. Another scathing rebuke of our industry. So the point I'm making is we need to be very deliberate and put the scientific process in view, particularly clinical trials, well-designed clinical trials, randomized controlled studies where possible. They're not easy in surgical disciplines, but they're possible. Because not only is that going to give us confidence that the new technology is going to be an improvement, it also can protect us against some of the disasters, and perhaps more to the point, it will get people to pay for it. And because as Case mentioned, that is a real challenge with some of these new technologies. In this era of declining reimbursements and bundled payments, where now even the surgeons incentivized to not use new technology because they'll make more money if they use cheaper implants. It's the bar is getting higher and higher and higher for this new technology to get introduced. And the way to do it is to have the evidence. Now the challenge is, how do we get that evidence, and how do we do it in a way that's affordable? Because doing clinical trials is very expensive. That's another matter. Whereas I look to the promise of robotics right now in its current form, I think others mentioned, it would just slow the surgeon down, and my high volume, very successful surgeons in my institution don't want to get anywhere near it. It's going to slow them down, and it's probably not going to improve their outcomes one iota.
Yeah.
Thank you.
I could not agree more. Let me just give a slightly different view of that. I fully agree that a fool with a tool remains a fool, right? So you can't make, the sports medicine doctor was thrown a little bit under the bus, but I get your point, right? I mean, people that are not trained to do something suddenly may think, hey, I have a tool and I can suddenly do this just as well. I mean, that's obviously not true, right? So you still need to be very careful. But I can tell you that at least in spine, where the robotics industry is excited about new developments. There's 4 companies that will have robots soon or have them right now. We've done the first studies both retroactively in more than 700 patients, and then we did something called the refresh study, which was a prospective study, and it clearly showed a 6 odds ratio reduction in revision surgery for long construct MIS, adult scoliosis correction, and an 8-fold less odds ratio, of 8 of lesser complications across the board. And this is not just because of the robot. This had to do with patients that had that type of surgery with the robot had less soft tissue inflammation and dissection, so they got out of bed earlier. So the DVT rate was lower. Their pulmonary complication rate was lower. So it's not that when you use a robot, suddenly the patient won't have a post-op UTI. I mean, those links are not there in spine, of course, directly. But motion is lotion, right? Early mobility protocols aided by less traumatic surgery will help patients that get out of bed and have a reduction in complication rate, revision rate, readmission rate, and so on. So there is indeed, to your point, a wealth of enthusiasm, and we almost try to outpace our own evidence. But I think that the guys that are doing this carefully, and we were part of this early study with the early adopters, right, have shown that there is a tremendous benefit for this. And robotics are a little different than implants, right? Because what you mentioned, what is primarily like being touted to the general public is mostly like implant-related stuff, right? You give us something, you get paid lots of money, but it wasn't tested well enough, and oh my God, now there's a complication. It completely goes away from, was it put in correctly? Was the indication by the surgeon correct? There's millions of things that are not nuanced in there. So, but we have to be careful. We have to be extremely careful with this. But I think the future is bright, and as long as you're willing to take a little bit less money for more advanced technology, I think together we can make it happen.